Well, it is, I think it is time to get going. Good morning, everyone. I am Dana Murphy-Parker, and I am the president-elect of the International Nurses Society on Addictions, which we call INSA. And INSA is very happy to offer this PCSS webinar this morning, Opioid Use Disorder in the Nursing Profession. We have Kristin Waite-Labott, who actually is the current president of INSA USA. Then we also have Lynn Lenzmeier. We met April a few months back. She is working on her DNP at the University of Minnesota, and she is her capstone project is certainly about nurses and substance use recovery, and she's doing an online kind of big support group room that's very, very interesting for nurses who are looking for support in their recovery. And then we also have Rachel Shuster. Rachel is actually, she was our secretary on the INSA Global Board, and we're just delighted to have her back. She's been laying a little bit low over the past 6 months or so after the birth of her and her husband's first son, Ethan. So these are our presenters, and I think you're in for a really interesting talk. So the title today is Opioid Use Disorder in the Nursing Profession. Objectives are to understand the scope of opioid use disorder in the nursing profession, to identify the risk factors in nurses for development of opioid use disorder, and to develop the ability to recognize a coworker with opioid use disorder and refer them to helpful resources. We also have some information, I think, just in terms of general recovery from substance use disorders. So thank you everyone for being here. Robert, if you'll go on, I'll take care of our beginning slides. So PCSS, the Providers Clinical Support System, is a collaborative effort led by the American Academy of Addiction Psychiatry in partnership with all of the professional organizations that focus on addictions that are listed here. Obviously, INSA has a contract with them, and we provide 4 webinars a year. Okay, go ahead, Rob. Our target audience and our overreaching goal for PCSS is to train healthcare professionals in evidence-based practices for the prevention and treatment of opioid use disorders, particularly in prescribing medications, as well as the prevention and treatment of substance use disorders. The presenters will make note of any disclosures that they have at the beginning of their presentation. Just before I turn it over, I want to remind everyone we're very excited. We had planned to go to Calgary, Canada, Calgary, Alberta, Canada in October of 2020. And of course, COVID prevented us from doing that. We thought maybe last year, but that didn't work out. But we are on with our plans. We will be having INSA's 45th conference in Calgary, Alberta, Canada. And so all the information and how you register and the program when it gets put together will be available on the INSA site. So please join us up in Canada for this. Okay, so I'm going now to turn it over to Chris. And Chris, I'll let you take the lead and introduce your colleagues here. And we're just ready to hear everything you all have to say. Thank you.
Well, thank you, Dana, and welcome everybody. Thanks for joining us today. April, Rachel, and I are going to share on opioid use disorder and in nursing and share kind of our personal stories, hoping to decrease the stigma that goes along with substance use disorder, in particular with nurses, and maybe just kind of educate folks on the fact that it's around and that people really can recover and return to safe practice. So as Dana said, my name is Kristin Waite-Labott. I'm the INSA USA interim president and have been on the board of INSA Global for a couple of years now, and really love the organization and what it stands for and the collaboration, networking, and education that we can get and share with each other through it. So that's why we're here today, because of them and PCSS. So very grateful that we get to be here today to share with you, and grateful that you joined us. So I think I'll start with some statistics. So just to kind of put a face on this disorder in nursing. The NCSBN, or the National Council on State Boards of Nursing, estimates that 10 to 15% of nurses suffer with some form of substance use disorder, and that 6 to 8% of them are using at a rate enough to impair their practice. I don't think those statistics are probably new to anybody. They've been around for a long time. And my guess is that they're a little low, particularly after the pandemic and the ensuing stress, and stress is a mild word to put on the healthcare system and nurses in particular. So, but keeping those numbers in mind for a moment, diversion incidents, at over 90% of them are due to opioids. So talks to or speaks to the addictive nature of opioids. You know, we have, as nurses, at least if you work with controlled substances, we have fairly easy access to them. And so when you couple the stress of the job and maybe life stressors with easy access, that's how you kind of get the incidents that we have. So to put it kind of into perspective or into context, what those statistics mean. If we look at that 10 to 15% of nurses that suffer with some form of substance use disorder, we'll use the 10% number because I like easy math. The United States has about 3 million nurses, at least as of 2019. I imagine that's changed a little. But as of 2019, 3 million nurses. If we use that 10% statistic, that means there are about 300,000 nurses in this country alone that suffer from some form of substance use disorder. That's a lot of nurses. And then if we use the 6 to 8% of them are working impaired, that's 180,000 nurses. If you think about that, I just want to let that sit in for a few seconds. 180,000 nurses that are struggling terribly with this disorder throughout this country. Those are the nurses really that I would like to reach. Stigma prevents us from reaching out for help. That stigma, or the negative attitudes someone has maybe against a group of people or towards a group of people, that stigma that tells the nurse the shame and that disgrace that will ensue if they come forward or they say, I have a problem and I need help. They may be fired, lose their nursing license, lose their insurance and ability to support themselves and maybe their family. They know that they will be judged and looked down upon by their peers. And it's really difficult in those circumstances to raise your hand and say, I have a problem and I need help. I think by sharing our stories, and our stories, you know, the ugly part of it, but even more importantly, how we got better and how we stay that way and how we can return to safe practice. I think by sharing those stories, we can help decrease that stigma, help leaders to understand that they don't have to fire a nurse and level charges against them. They can keep them on, offer them a medical leave, help them to get treatment, and help them return to safe practice. It really is possible, and so important, especially today, and in the, you know, the way that nursing is moving today after the pandemic and staffing and all that. I'm sure that I don't have to go into detail about that. So having those statistics and in mind, I just want to share my story, however briefly. So I've been a nurse for 30 years, which is almost impossible for me to believe. It'll actually be 31 next month. And I've been in recovery for 17 of those years. My substance use really started in college. In 1985, I went away to Winona State University in Minnesota and was really ill prepared to be on my own. I had a lot of anxiety. I was super excited, but I had a lot of anxiety. I had no idea really what I was doing. And I was introduced to alcohol, as most, you know, freshmen are. I found that alcohol just completely made that anxiety go away. And I felt so much better. I felt like I was one of the crowd, and I could get along with my peers without worry and without feeling insecure. And it just felt really good. So I found myself drinking a lot. In fact, it took me 6 years to get my 4-year degree because I had to repeat some classes. I had my first daughter in my 4th year of college, and really having her kind of cleaned up my act for a little while because I knew I wanted to take care of her, and to do that, I thought the best way would be to be a nurse and make an income. So I did graduate, and my drinking over the next few years was, in my opinion at the time, it was fine because I didn't go out. I drank at home alone after my daughter went to bed until I passed out, which, I say that now and it sounds like that's not normal. But at the time I was like, I'm doing really good. I'm not going out. I'm not partying. I'm staying home. So I did that periodically, and I was not a daily drinker. I was a binge drinker for sure. In 1997, I had a minor surgical procedure and was prescribed Percocet. I found that I loved the Percocet. It did that same kind of magic on my anxiety, but I didn't have the effects of alcohol, like smelling bad, stumbling around and slurring my words, that kind of stuff. And so I took that Percocet until they were gone, even after the surgical pain was no longer there. I called in for a refill for those Percocet or on that prescription because I wanted the pills more, but I didn't have the surgical pain, or I wanted more of the pills. After that, over the next few years, I would exaggerate back pain and go to my doctor and get Vicodin. I got married in 99. He was a carpenter. He hurt himself on occasion and would get pills, and like a good husband would share them with me. I called in a prescription refill for him once that he knew nothing about, and I snuck pills from him. I did that kind of thing maybe a handful of times over, in the late 90s. Sometime around the year 2000, I was working in an emergency room and realized that we throw away a lot of really good drugs. And unconsciously, subconsciously, I don't know, I just put the waste from one of my patients in my pocket and took it home that night. It was IV, and I took that at home. I remember very similar, that same relief of anxiety, only it was much more intense and it was immediate. And so it was the same kind of thing, like, holy cow, that is amazing. I love that feeling. And so over the next couple of years, I took waste whenever I could. It was limited only to waste, and I had myself convinced at the time it was no big deal because it was garbage. Of course, it was a big deal, but denial is very powerful. And even though I'm a reasonably intelligent person, had myself believing that it was no big deal. And then one day I had leftover fentanyl, and I took that. From that moment on, I lost the choice of whether or not I was going to use. That opioid, I'm sure you all are familiar with fentanyl now, but that opioid was so strong. I was also going through a divorce at the same time. And I think the combination of the powerfulness of fentanyl and my extreme depression with that divorce together just created a disaster. It was from that point on, I had to have something every time I went to work. And when I say that, I really mean I had to have it. All the way to work, I would be telling myself, I'm not going to do it anymore. I'll never do that again. I don't need it anymore. But I would walk in the doors to that hospital, and it would literally pull me into the, to get the medication. I just could not say no. And so if I had waste during my shift, that was fine. I would use that. But if I didn't, I stole fentanyl from the stock. It got to the point at the end where I was just stealing it. Like, I just wanted that fentanyl. It's so much stronger, and I couldn't say no to it. So it doesn't take too long for them to figure out what you're doing when you do that. So I was caught. I was fired from my job. I lost my nursing license, and I ended up spending about 4 months incarcerated. It was extremely traumatic, as you can imagine, but it really was what I needed. That was my bottom. After jail, I did not want to ever be in that position again. And I've been sober since then, clean and sober. But it was just overwhelmingly difficult. It took a couple of years for me to get the courage to ask the nursing board to reinstate my license. And I probably never would have done that had my therapist not really encouraged me to do it. So I petitioned the nursing board, they granted a restricted license, and I joined the monitoring program here in Wisconsin. It's a 5-year program. I completed that program in the 5 years. And I have my full licensure back now, and have since. I've been working as a nurse now since 2007 again. But that program was overwhelmingly stressful and scary, to put it mildly. There was no program or peer support then, at least in Wisconsin. I knew no other nurses that were going through it, and I struggled. I didn't struggle with using. I struggled with fear and anxiety. I just was sure I was going to make a mistake and they were going to pull my license and it would all come crashing down again. It was just really difficult. I'm very grateful for the program, because had it not been there, I wouldn't be a nurse again today. So I'm very grateful for it, but it was hard. And some of the work I do today, I'm a nurse coach or a nurse recovery coach for nurses going through very similar circumstances to what I did. And it's for a virtual treatment program called Veritas, and it's for medical professionals. It's virtual, so I get to work with nurses from around the country. And what I've learned in that work is that there are states that have pretty cool peer support programs for nurses going through those programs and going through monitoring, getting sober, returning to practice, and because it's a big deal. It's difficult and it's stressful. And when I learned that, I thought, why in the world don't we have that in Wisconsin? So last year I started an organization called Wisconsin Peer Alliance for Nurses. It's a nonprofit peer support organization. We do peer support for nurses, run by nurses in recovery, me being one of them. And we do education. So we go around the state speaking to, hospitals, colleges, universities, clinics, and the public when asked to share about this problem, how to recognize it, and what to do if you do recognize it. So really grateful for that experience of coaching so that I can learn how I can help nurses here. So I think it's such an important part of the recovery process for nurses, is having someone to talk to that's been through it and can guide you and just support you and comfort you. And then the other thing that I've done is wrote a book about my journey. It's called An Unlikely Addict. And I don't necessarily say that to promote the book, but I think that sharing our stories is so important for 2 reasons. I mean, for a lot of reasons, but 2 main reasons. One is that so other nurses know they're not alone. Because I will tell you, when I went through this, I thought I was the only one. I thought I was the worst nurse. It was devastating to me. And I learned I'm not nearly the only nurse. If you remember, there's 180,000 nurses practicing impaired like I was that need our help. So I wrote the book to let people know this happens and come talk to me so that we can work it out, figure out how we can get better, figure out how we can reach more nurses. And my peer support organization, again, it's just so important that nurses have someone that they can talk to. And I can't tell you how meaningful it is and how powerful it is for one person who's been through such a traumatic experience talking to another person who maybe is just beginning that and doesn't have any idea what to expect or where to turn. And I've talked to lots of nurses now that fit that category. And it's so meaningful to me, and it's very meaningful to them too. So I really believe strongly that sharing our stories is one way, at least, to decrease that stigma and help people understand how to recognize it and where to send folks if they do. So I think that's about all I have to share with you today. Again, just thank you for listening. We're going to be sharing a resource document with you where you can reach out for resources and maybe learn more. Our email addresses are on that document. If you have an occasion where we could share our stories, or if you have questions, please reach out to us. We would love that. So I am going to turn it over now to April, and she's going to share the awesome work she is doing too. So thank you.
Thank you, Kristin. Excellent job. Love hearing your story. Thank you, Dana. Welcome, everyone. Thank you so much for having me. I am April, and I am a nurse in long-term recovery. I am so thrilled to be here to talk to you today. However, it's newer for me to talk about my experiences and my journey. I'm really blossoming after I am finishing school and used my substance use disorder as fuel to kind of drive what I'm going to talk to you about today. So it's very exciting. I'm one of the statistics that Kristin talked about. I have a substance use disorder and I've had it since I was 12 years old. That is when I had my first drink, sadly. As I had two daughters and as they were turning 12 years old, it was such a significant thing for me to experience such a child in such a young age, to be starting my journey and my career into substance use disorder at such a young age. But I finally got help when I turned 40. And I had a 28-year career of problem drinking and substance use disorder. But I want to talk to you about a little bit about my story, a little bit about what happened to me, but really want to hone in on how it is now, how I got into recovery, and what my plans are to reach other nurses and get them the help that they need. So how was it for me? Well, problem drinking for 28 years is not an easy life. I was an ICU nurse for about 10 years of my nursing career. I know I have PTSD from that nursing experience. I know that I saw and dealt with things that I didn't know how to cope with. I know that I was internalizing the pain and suffering of my patients and their families. And at the end of my shifts, I was drinking and I was using. I did it through school, 2-year degree, 4-year degree, part of a master's degree, CCRN certification. I was an excellent nurse. I don't know if others would have known how severe my problem was at work. I know management and leadership didn't know. My story is unique. I didn't have a licensure problem. I didn't get into trouble outside of my own soul and my own morals. But it caught up with me. So what happened to me? I hit my rock bottom. I could no longer care for myself. I got into management just prior to that, about 5 years prior to that. And boy, management brought it to a whole nother level for me. I went from an ICU nurse to a nurse manager, and the stress and the complications that I had to face were beyond what I could have ever imagined. And my drinking, as it's a progressive disease, progressed. And I was broken. My health and my sanity was at jeopardy. I really didn't know what to do, who to talk to, and what help and resources were available to me, because the organization that I worked for in Minnesota had no communications about it, had no resources, had nothing for me they did, I found out later, but nothing that was readily available to me, nothing that I had access to. It was my shameful secret that no one knew about as I tried to do this difficult work in nursing and nurse leadership. I didn't reach out. I quit my job. I just quit my job. I didn't know what else to do. I couldn't do it anymore. And I was fearful of my staff finding out. I was fearful of harming someone or somebody or something. And so I quit. I had a midlife professional and personal crisis, and I had to figure it out, and I had to get some help. So I want to talk about how it is now for me. I got that help. And sobriety and recovery has opened doors for me that I didn't even know were there. What ended up happening is I found a nurse leader here in Minnesota through some other networks and some other colleagues that brought me into the Minnesota Nursing Peer Support Network. I found out that they were doing all of this work behind the scenes for nurses in Minnesota with substance use disorders, opioid use disorders, alcohol use disorders, and they were trying to reach them, and they never got to me. And so it started to become my passion to figure out how to get to people and nurses just like me. And I wanted to study why it didn't reach me and how come I had to spend all of those years as a bedside nurse and a nurse leader suffering alone in that conspiracy of silence. So this nurse leader that brought me through the program and got me into some help and got me into peer support meetings in Minnesota, she also encouraged me to go back to school for my doctorate of nursing practice. I told her she was nuts. That's not for me. That's what smart people do. I told her that, you know, people like me who have the challenges that I have, the disorder that I have, and the use problems that I had, I wouldn't be able to figure out how to do that kind of a program. But like recovery and like sobriety, I surrendered and I listened to other people rather than myself. And I listened to her as she guided me and mentored me. I got into the program and I was accepted to the program for health innovations and leadership as my specialty. And I had to do a project. And I had no idea what I was going to do. And I first thought that I would do CLABSI prevention because I was good at it. We brought CLABSI rates in our hospital from 7 a year down to 0. And I did the full PDSA cycle and figured out how to do that. And I just knew exactly how to speak to that. And I could slap that on paper as a project. And my professor said, you can do that and you'll get an A, but you're not going to grow. So I want you to stretch and expand yourself. So what I did is I decided that I would take my substance use disorder and I would turn it into the fuel to put into my project. And I did that. And it has been so successful. It's the reason that I'm here today. I have been able to get involved and partner up with the Minnesota Nursing Peer Support Network to bring Nursing Peer Support Network meetings to a global format. And we started with 3 nurses for our online meetings 3 years ago when I started the project. And I convene the meetings every Tuesday. And it has grown to an average census of about 110 nurses. And part of the reason we have grown the way that we have grown is because the dissemination plan for my project was to reach organizations and talk to leaders about substance use disorder, about a standardized approach to manage it and support nurses and hook them up with other peers. And you can't just talk about that, you have to act on that. So I decided to figure out how to get into the organization's website. The conspiracy of silence, I just want to touch on again. There were no resources, like I mentioned, for myself. And during my studies in my project, I audited 2 other major healthcare organizations in Minnesota that also did not have resources available to nurses. The resources were there if the nurse asked for it, like through the employee assistance program or HR. They would may or may not know about something. So what I did is I worked to get a link embedded on the wellness page of the organization's wellness page. On that page was everything from smoking cessation to how to lose weight to how to keep your cholesterol numbers in check, but nothing about substance use disorder. When I reached out to the HR director, I want to tell you something very painful that happened. I asked if I could send out an email to all nurses to just say, hey, all nurses in Minnesota that work for this organization, there's a Minnesota Nursing Peer Support Network that you may not be aware of that can help you if you're suffering with opioid addiction or substance use disorder or alcohol disorder. And I wanted to just send that email out with a HR's approval stamp. And they told me that I could not do that and they would not do that for me. And the director that I spoke to said that it would not be fair dissemination of communication. And she gave me an example that it would be similar to a nurse requesting to send out Girl Scout information if her daughter was going to be selling Girl Scout cookies to others in the organization. And that was a knife right through my chest, that the HR director thought that comparing a substance use disorder communication would be the same as selling Girl Scout cookies. And so I knew that I had to transform culture. I knew that I had to get in there and figure this out, that this was not as easy as I thought it was going to be. And that's when I started digging and found the wellness page. So I reached out to the wellness analyst of the organization. Believe it or not, the wellness analyst is the one who said, oh my gosh, you're right. We have all of these things for nurses, but we don't have a link. And I said, can I drop the link to the Minnesota Nursing Peer Support Work and the CDC's guidelines, of course, for opioid use disorder, substance use disorder, and alcohol use disorder. Can I drop those resources in there, as well as the international resources for international and global recovery network sites? She didn't know, and of course she had to ask her leaders for permission. She put a stat out for it, and by the next day, less than 24 hours later, I got approval and synced the links. And the meetings just started to grow. I started to ask the nurses when they showed up, how did you find out about the meetings and how did you know we were here? And they were starting to say the organization that I work for had a link that my leader was able to direct me to. So it's so important for me to come here today and share this story with you from my personal experience, but then really about how to reach people in organizations or that you know through other ways than just talking about this. We have to act and we have to make it available. We have to bring it to the nurses somehow. We can't expect them to come to us, especially when they're suffering and they're sick, they're scared. And the conspiracy of silence is so strong and so real. That would be my other takeaway for you today, is to remember my experience and to just remember that there isn't a place for substance use or opioid use disorder to live. And people were turning me away and telling me, no, I can't help you with that. And so this is such a serious thing, but look at us now that we're in recovery, and look at the power that recovery can bring once that help is provided for nurses. So the sites that I spoke of are going to be in that reference page that Kristin talked about that you'll receive. And I thank you so very much for your time and your attention and your hearts today.
All right, so I think that leaves me to start now. Thank you so much for allowing me to be here, and thank you for being here. My name is Rachel Shuster. I am a registered nurse and person in long-term recovery from a substance use disorder. My story is mental health. My story is bullying. My story is opioids. My story is alternative to discipline and monitoring programs. My story is privilege. My story is recovering out loud. And though the journey was difficult, my story is strength. I graduated nursing school in 2012 and started my career in the critical care unit. After working at one place initially, I had gotten engaged, so I moved to a job also in a critical care unit closer to home. I was planning a wedding, doing all of this stuff, and I think that once I got engaged, switched jobs, planned the wedding, bought a house, got married, all of this high achieving background that I had really just kind of came to a T. I was so used to having all these after school activities in high school and then in college being highly involved in so many things. I didn't really know how to sit with myself. I had never really had that much time on my hands. So I started to feel very uncomfortable with a slower paced work lifestyle. It left me feeling empty and wanting more. On top of that, I was dealing with some horizontal violence at work. And I think this is something that's not talked about frequently enough. That definitely, along with other things, affected my mental health quite a bit. It's terrible to go home and just have all of this anxiety and panic surrounding going to work. And I knew that critical care environments were ones that often attracted these tougher personalities sometimes, but I just did not expect to have this particular individual and those that were kind of in this alliance in a way, targeting me in such a passive aggressive way that made me feel as if I had to fear for not only myself but also my patient's safety, particularly when getting report from this individual. And would this person do something to set me up in a way? I had all of these thoughts, which were most likely a lot of paranoia, but they were growing and being fed by legitimate things that were happening. And this is something that I think that management needs to address in a lot of ways, because I did go to my manager. I, at that time, didn't have the assertiveness that I do now, and would have, in retrospect, wished that I had gone up the chain of command, gone to HR. But I was a new nurse. I was fresh. A couple of years under my belt. And, this really led to a worsening of my depression and anxiety at that time. So I resorted to what I often joke. We're not laughing, we're crying sometimes. So I joke that achievement is my original drug of choice, right? It gives me that same dopamine rush. I like being told good job. It feels good. So I was working full time in the critical care unit and began teaching nursing part-time as well, doing clinicals with first year nursing students, as well as going to grad school part-time to become a family nurse practitioner. And this led to minimal time for self-care. I began utilizing a more harmful coping mechanism. And oftentimes people ask me why that first time. I was 25 years old, and I think I'm a risk taker at baseline. It seemed to make my patients feel good. I knew the doses, I knew the side effects, I knew how to do it. I had the equipment. There's often this stigma attached to use of street drugs, and therefore all of this rationalization and justification of using something at the bedside that, oh, it's a sterile supply, it's something that, I can just use the waste, I'm not hurting anyone, it's going to be thrown away anyhow. So oftentimes it's really difficult for me to understand even myself why that first time, because I don't have a great answer for that. But for me, it was like all of the stars aligned. I didn't have the support that I needed in a place where a crisis was worsening. And, instead, I just was curious. It wasn't a why, but it was why not. And of course, that first time I used, like I said, my story is opioids. I did not have any sort of progression of use where I started out with pills or anything like that. I did divert and use fentanyl the first time I used, and that was my drug of choice. I felt like I could do what I needed to do without having these uncomfortable emotions in the way. And I felt like I was back to this high achiever that I thought that I needed to be. Of course, as we know, substance use disorders progress. There was a lot of obsession and compulsions that grew. My use started out as sporadic and grew into something that was more frequent, use of higher amounts of the same substance to achieve the same effects, riskier use, and oftentimes even uses of other substances when I was unable to access my drug of choice. This changes the brain's reward pathways. Nurses, healthcare professionals were not immune to this same disease process as any other individual. So for me, because of the 312 that I was working, I had mild physical dependence, if at all, but the psychological dependence was unbreakable for me. It became this endless cycle where it was just once more, okay, this is going to be the last time. After this, I'm done. This is just it. I hate how I'm feeling. I hate this guilt. I know what I'm doing doesn't get me to where I want to be. I don't like all this fear I'm having. And then I used, that was the last time, I'm done. But then it would just magnetically almost draw you in when there was another opportunity to use. And of course, this made me feel so terrible. And the thing that made that go away was continuing to use. I did have some family initially figure out about my use about 3 months into my struggle. And at that point, I got involved in some outpatient treatment and started oral naltrexone, but I didn't really want to commit to long-acting injectable naltrexone. That felt scary, and like, why put a medication in my body? Because of course I was being very holistic and trying to get all these chemicals out of my life. Meanwhile, I'm using fentanyl and injecting that. So there was a lot of controversy. These two personalities almost pulling at one another. And I definitely did have some ambivalence about wanting to stop, because people don't use drugs just because they have all the negative consequences. There are positive effects to substance use. So it was me wanting to keep those positive effects while removing the negative consequences. I took the oral naltrexone on birthdays, and there were certain days that I felt like, you know what, I'm not going to take it today. I'm strong. I got this. I got myself a bracelet that said "Be strong" and had a little green triangle on it that was a symbol of mental health awareness. And I thought, when I go to use, I'm going to look down at this. I'm going to see it. It's going to remind me that I don't want to do this. And it didn't work. I tried everything. I even got this ridiculous bracelet that was supposed to like Pavlovian shock you, like you could shock your way out of habits with like a negative consequence. And you know, try to quit smoking and I was like, I'm going to shock myself anytime I think about using it at work. I'll do that. It didn't work, right? All of these things I'm trying to just make it happen, but I felt above knowing the help that was available to me. I felt like as a nurse, like that wasn't for me. It was very much kind of this like high horse that I was on, and the stigma that is just so pervasive in our society really led to that for me. It wasn't to anyone's fault. It was just the world that we're in. That's how I felt at that time. My relationship with my husband was very difficult at that time as well, because I was diverting and injecting. I was lying. There was a lot of manipulation, which I use as a very careful term because it wasn't nefarious. It was just trying to continue the benefits I thought I was having without getting other people in the way of the tornado that I was at that time. I had a lot of marks and bruises on my arms and legs and made excuses about that. And I point this out because it's very important to talk about my relationship with my husband at that time, because this is often what is considered a family disease. And because of those marks, I didn't want to be intimate with my husband. I felt like I needed to hide this physical evidence of my use, and that further deteriorated our relationship at that time. I ended up using for the last time on July 15th of 2016. It was the second night shift of a stretch of 6 in a row, and I had a patient who was crashing, a lot of respiratory issues. And of course, when we intubate someone, we often start a fentanyl drip or other medications that are similar to keep them sedated and comfortable. And when we ended up re-intubating this individual, the pharmacy sent up another bag of fentanyl drip, and I went to hang it, and the bag from a couple days prior was still there. So I wasted that with my charge nurse, and what I had actually wasted was not the substance itself. I diverted that for my own use, and shortly after midnight, went into the bathroom, started an IV on myself, and used that bag with gravity tubing. I had used what I thought that I wanted, and continued, looked at what was left and thought, this is not going to be enough for later. I might as well use it now. And it was shortly thereafter, I remember stumbling back, and that's it. About 2 hours later, I was found by coworkers, code paged overhead, staff bathroom. Of course, that caused a lot of gossip. I was administered naloxone, which I often talk about as well, because it's important to squash this whole idea of Narcan parties and like people just like trying to get as high as possible and stuff like that. It's just not a thing. Remember, I said I didn't have a lot of physical dependence, and let me tell you that the way I felt after being given naloxone was absolutely horrid. I felt terrible. After I was discharged from the hospital following my overdose, I was just given these normal discharge instructions. I don't know for sure, but I felt like a lot of nurses didn't want to come in my room. They probably knew I was a nurse, and they probably felt some type of way about what I did. I was just given this packet of resources and very simple discharge instructions. None of those led me to the one thing that was going to save my career at that time, and that was the alternative to discipline program. Of course, I knew that the hospital was likely to turn me in, so that weekend I called myself, and at that point still had a lot of ambivalence. I still had a lot of denial about the severity of my disease process at that time. And Just figured if I got ahead of it, this is going to look good. This is going to give me my best chance of keeping my life as I know it. I found the Pennsylvania Nurse Peer Assistance Program and the Pennsylvania Health Monitoring Program by Google, just Googling nurse substance use problem. And, I never heard about that. I didn't learn about it in nursing school. I didn't hear about it when I started my job. I didn't know anyone that had been in it. There's a lot of people that I know now, oftentimes that aren't recovering out loud, and that is okay. But because there are so many people, because of the stigma in our world, that are recovering in their own shadows, it's very isolating. You don't really know where to go for help. And even when I went to treatment, I really felt like, man, if I could just connect with another nurse who's been through this, I need to talk to someone. I have so many questions, like, is my life over? Of course it wasn't. I ended up going through the whole gamut of treatment: inpatient rehab, PHMP, IOP, outpatient treatment. I did enroll in the monitoring program, and my criminal charges were decreased to ones that were not drug charges, which I highly advocate for as well, because I have a friend of mine who has a very similar story to mine, same state, different county, same attorney, different counties, and her charges were not dropped from a drug charge. Mine were. She had to go the disciplinary monitoring route. So this individual's license, if you look it up online, despite her successfully completing the program, it will always be tied to her license. You can see all of her documents that are attached to it. Mine is voluntary and anonymous. If I wanted to, I could have just put this all behind me, but I feel like it's very important for me to stand on this platform now and tell my story and recover out loud, because we got to squash the stigma somehow. I just really feel like if we bring it into the light, this is really what's going to make that difference. But the drug charges, just putting someone into this disciplinary track can alter so much. When she applies for a job now, that she can't hide that. It's just always going to be there. I do also like to just mention some of the costs associated with this program, because that is a huge part of my story as well. Not only did I have some costs related to my attorney and criminal things, and loss of my insurance because of the loss of my job, but these programs, you're often required to do drug screening multiple times a month. You're randomly selected. I check in every day, and if I got selected, change of plans, got to go do that urine drug screen or blood or whatever they wanted. And there are associated costs not only for the test that an individual has to pay out of pocket in Pennsylvania, but also the cost of the copay at the facility. And oftentimes these urine drug screens are called liquid gold for a reason. There's a lot of income tied to it. And there was one facility chain in Pennsylvania that increased their costs from, I think it was like $30 the whole way to $67.50 by the time I was done with my program. And that didn't account for the cost of the screen itself. So, there's definitely some improvements that I think can be made to support nurses in recovery. And some of those I'd like to my own horn a little bit. An article that I published in the Journal of Psychosocial Nursing in 2021 about my story and about some of my suggestions and criticisms to these programs, because there's no doubt in my mind that these programs are good. They do have a benefit, but I would be remiss to not say that there weren't improvements to be made, because where isn't there improvements to be made, whether it's your workplace or whatnot. There are ways that we can better support our nurses. I also like to mention that when my criminal charges were filed, I made the front page of my local newspaper. And I mention that because media, journalism, news, not kind. The words they use, the connotations to the words that they've used are very difficult. And if I was not in a place, I was 6 months into my recovery at that time, if I was not in a place having the coping mechanisms that I learned throughout treatment and throughout mutual aid support groups, and did not have the amount of people rallying around me that I did, I can guarantee you that I would either have been admitted for a suicide attempt or would not be here today, because it was just awful feeling like I just wanted to turn the lights off in my house, hide in a corner, felt this fear that the news was going to show up outside with these blaring lights. I'd had it happen to friends, and I'd heard those stories by that time. So I had so much fear. And along with that, I was carrying my husband's name because I was married. So I felt terrible that, you know, my mother-in-law had to go to work and have questions asked of her, you know, these people that didn't ask to be pulled into this. So, you know, this is definitely something that is a passion project of mine. I could talk about this forever, but I recognize that we are getting near to time, and I'd like to leave some time for questions and anything that anyone might want to ask of Chris, April, or myself. But I just want to say thank you for allowing me to be here. It is an amazing privilege to be able to share my story. We need more people sharing our stories, particularly people that don't just look like us, because I realize we're a very homogenous group here today, and that's amazing. I hope that we're sparking this with multiple people that can hopefully better represent the nurses that are struggling, that are in recovery. And I will end with just saying that I guarantee you, if you're going to a restaurant, if you are going to work, if you're at the grocery store, you are bumping elbows and rubbing shoulders with someone who is in recovery and or someone who is struggling. So be kind, learn more, smash stigma, and thank you.
Thank you, Chris, April, and Rachel. Thank you so much. I mean, I've known Chris and Rachel quite a while now, but I certainly feel like I know you a little bit better. And April, your story about the Girl Scout cookie is about one of the most sad but almost funny, you know. We'll have to get you to tell that again at some point. There may be questions. There is someone, Kim Harris is asking in the chat, do you all see yourselves as different as a person with addiction, and did this hinder you in your treatment and your recovery process?
I can speak to that a little bit. Just if I'm understanding the question correctly, when I went to treatment, I kind of, you know, of course they joke, nurse jockey, all that stuff. And it took some time for that acceptance piece to set in. I was very othering for a while, and then I started to really notice this wasn't so much about what we use, these backgrounds, or how we got what we needed, but more about the similarities, this underlying pain, this underlying discontent, what we were looking to seek out and numb. And through discovering that, how I feel, connection is the opposite of addiction, that it was through that I realized we aren't so different, that people really do have these underlying feelings. We're all struggling to just make ends meet every day. We're all struggling to just do the best we can with what we're given. And I think that initially it did hinder me in that acceptance piece, but I don't really see myself as different now. I think that we all just are working with what we're given.
I can comment really briefly. Just I was able to experience a healthcare professional's time of treatment at Hazelton here in Minnesota. They have a healthcare professionals program. And when I was broken in between my nurse manager job and my recovery, there was that period of time I talked about where I was lost and broken and without a job. I walked into that treatment program, a nurse. They asked me when I walked in there, who are you and what are you? And I'm like, I'm a nurse and I'm screwed because I have nothing. And they taught me to be April 1st and a nurse second. And when I left that program, I came in as a nurse and I left April. And I think that is such an important thing to remember when working with nurses in recovery is oftentimes we feel like we would be nothing without that license. And when nurses lose their license, they're at risk for suicide. If they can't get a job, they're at risk for suicide. If they are under investigation or they can't get that next job, or they're dealing with a manager or a nurse leader that they feel like is going to take their whole livelihood away from them, they can't handle that, and they are considering ending their life. So I just wanted to share that real briefly, that I was a nurse first and I am April now first.
That's very good. That's very good. Anything else, Chris? You want to add something there?
No, I think they covered that well.
Okay. Okay.
Yeah.
Okay. Well, it is getting very close to 11 o'clock. So again, thank you so much, Chris, April, Rachel, very valuable. Robert, you'll have to make sure that Chris and April and Rachel get what's been going on in the chat box, because hats off to all three of you. There's some wonderful comments about the work that you have been doing and the work that you're sharing and your whole story. So thank you so much. I'm going to go ahead and end now by saying that a little bit more here about the PCSS program. The PCSS program is a SAMHSA-funded grant to the American Association of Addiction Psychiatry, operated out of Brown University in Providence, Rhode Island. And for the nurses that attend, we do, once you fill out the evaluation at the end, you will get a one continuing education credit. We do offer CEUs for nurses who attend these PCSS webinars through the International Nurses Society on Addictions, and that comes out of the California Nurses Association. So thank you again, everyone, for being here, and have a very blessed and great day. Goodbye.
Thank you. Take care, everyone.